Good morning, respected chairperson, teachers, senior colleagues. The topic is atrial fibrillation in elderly. As we all know, it's a disease of aging and multi-morbidity. As the age advances, your chance of developing atrial fibrillation also goes up. And as we all know, more than 80 or 85, around 15% of us would be having hypertension. The lifetime risk of developing atrial fibrillation is around 1/3. So the case given to me is of a elderly lady, 83-year-old. She is having permanent atrial fibrillation, history of cerebrovascular accident, chronic kidney disease, eGFR is 32. She is a hypertensive. And this is a common patient which we see every day in our OPD. Other details are not given, like the age of the patient, other comorbidities. So when you manage these type of patients, other details are important. Because if you strictly follow the guideline, randomized controlled trials usually exclude these elderly and frail patients from the study. So the guidelines are often age agnostic, but they usually don't represent this very elderly population in the data. So standard care without context can cause harm to the patient. If you look at the elderly patient, they may be having lot of other comorbidities. They may be having neurological issues, other hypertension, diabetes, other common issues, other orthopedic issues. They may be taking polypharmacy, multiple drugs from the neurologists, orthopedicians, multiple areas. So you have to shift the focus from just managing atrial fibrillation to a patient as a whole. Otherwise, you will miss the forest for the tree. For that, a unified multidisciplinary pathway to simplify decision making has been put forward by European Society of Cardiology in 2024. That's a roadmap. You go for AF care. And what's AF care? C, for you look at the comorbidities and risk factor management of the patient. A, how to avoid stroke and thromboembolism, or to reduce symptoms by managing the rate or rhythm. Again, that's a debate. And evaluation is for evaluation and dynamic reassessment of the patient. Let's see that one by one. If you look at the comorbidities, it's very important. These patients have a lot of comorbidities. Hypertension is one of the most common, and that could be the reason in many of the patients. You try to manage that. Target a BP to around close to 120 to 129. In very elderly, you may target it to less than 140. Heart failure, if there is heart failure, detect that, optimize the therapy. Diabetes, glycemic control. Obesity, if the patient is having obesity, try to reduce weight at least by 10% of the body weight. All these things are class 1 indication. Manage hypertension, heart failure, diabetes, obesity, class 1. And if there is sleep apnea, again, manage that properly, class 2B. And look for other comorbidities as well, like kidney dysfunction, anemia, look for the cognitive impairment, risk of falling, sleep apnea, etc. To know, next is to avoid stroke. For that, you have scoring system. Any patient who is having increased risk of stroke, also as the age advances, their risk of bleeding is increased. Or you can put it in the other way. We will be very apprehensive in treating the patients because these are high bleeding risk patients. But any patients who is having high bleeding risk, they will be having high thrombotic risk also. So here will be some update in the most recent guideline by ESC. They have removed the sex category as a criteria to calculate the risk. So female sex is a risk modifier rather than a risk factor itself. So do not penalize the gender. That's why they removed the sex criteria. But calculate the other risk factors. If your score is 2 or more, then class 1 recommendation to start anticoagulant. And if your risk score is 1, you can consider that, but it's not a must. But keep in mind one thing, any patient who is aged more than 75, automatically their score is 2. So any patient with atrial fibrillation more than 75, you need not calculate all these things, he is eligible for anticoagulant therapy. But our problem is we have to balance between the ischemic stroke risk as well as the bleeding risk in a frail patient. If you look at the scoring system, many of the factors like age, hypertension, vascular disease, all these things come in the scoring system of both stroke risk as well as bleeding risk. So the clinical reality is we often fear the bleed we cause more than the stroke we fail to prevent. And from if you maybe because the patient also will be very apprehensive. If you create a bleeding, there will be more paradoxical. So here in our particular patient, his CHAT score is 5 and has blood score is 3. CHAT score 5 means he has got high stroke risk. Has blood score is 3, high bleeding risk. So what's this dilemma? To anticoagulate or not? The most important question we face is, doctor, he falls a lot. Should I anticoagulate? That's the question. If he falls, the chance of bleeding is high, so he will have more complications. But this issue was addressed in one study, Mansong-Hing. This was published in 1999. Here, they calculated what's the risk of fall, what's the risk of problem in a patient, subdural hematoma in a patient who has frequent falls. A patient must fall 295 times a year for the risk of subdural hematoma to outweigh the benefit of stroke prevention. In other words, a patient with atrial fibrillation would need to fall nearly 300 times a year for the anticoagulation to cause more harm than benefit. So you need not remove the benefit from the patient. You have to consider strongly the anticoagulation in this patient. So what about the bleeding score? The bleeding score is you calculate the stroke risk just to identify who will benefit from anticoagulant. But here the bleeding risk not to avoid anticoagulants. Here, do not use bleeding risk score to withhold anticoagulations. If you find that the patient is having high risk for bleeding, identify the modifiable risk factors and modify that. So there could be modifiable risk factors and non-modifiable risk factors like age, prior stroke, CKD, all these things we may not be able to modify, but there could be some modifiable risk factors. Number one is hypertension. Control BP, and that's very common also. Control BP. Alcohol, the patient may be taking alcohol, limit alcohol intake, try to reduce it to less than 3 drinks a day, 3 drinks a week. Then avoid drugs like NSAIDs, aspirin, then assess the risk of fall. Assess environment. What's the cause of fall? It could be some sick sinus syndrome, modify the drugs and all. So modify this. Then once you have decided about anticoagulants, newer one, DOACs may be better because it has got a predictable effect and more important, lower intracranial bleeding. The risk of intracranial bleeding with warfarin is 1%, whereas here it's only 0.5. 50% less chance of intracranial hemorrhage, and there is no need for routine monitoring. That's very important in elderly patient. But mind one thing, many physicians may think the bleeding risk in warfarin or NOACs would be very high, then you can give aspirin. But mind it, minimal stroke prevention with aspirin at the same time, the bleeding risk is equal. So it's class 3. Monotherapy with aspirin to prevent stroke is class 3. And there is an exception. Suppose you get a patient who is very elderly, frail, very well stable with warfarin. His INR is stable between 2 to 3 and time in therapeutic range is more than 70%. Then if you switch this patient to NOAC, you will increase the chance of bleeding. So except in these type of patients, you go for DOACs, but in stable patients on warfarin, no need to switch. And in those patients who are not eligible for anticoagulant at all, for contraindicated because of recurrent GI bleed, then you can consider left atrial appendage closure. Now next is symptom relief. Here, by rhythm control versus rate control, most of the time the patient would be asymptomatic. In asymptomatic patient with long-standing atrial fibrillation, you go for rate control, that's better. There is no added benefit by going for rhythm control. But in rare situations where the patient is symptomatic with heart failure, then go for rhythm control, consider early intervention. When you go for rate control, what are the options? The best option would be probably beta blockers. Particularly many of these patients would be having coronary artery disease. You can consider calcium channel blockers like diltiazem or verapamil, but mind, LV function should be normal before starting these type of agents. Digoxin is a good choice, but in elderly you should be very careful because of this, particularly in this patient where the eGFR is only 32. And when you start antiarrhythmics for rhythm control, mind it, all antiarrhythmic drugs are pro-arrhythmics. You stop one arrhythmia and produce another arrhythmia. So you should be very careful. Dronedarone is not a choice at all, contraindicated in heart failure, toxic. Flecainide is a good choice in young patient, but in elderly, it's contraindicated because it's contraindicated in structurally abnormal heart and coronary artery disease. Most of these patients would be having that. Amiodarone is toxic in the long term, so it would be a good choice in elderly, but start low dose and go slow, because many of these patients would be having sick sinus syndrome. So in these type of patient, permanent atrial fibrillation, no cardioversion, no rhythm control, go for rate control, and the target heart rate, it should be a linear target heart rate control to less than 110 rather than less than 80. If you target for less than 80, the complication rates are more. Now the last one, evaluation. Frailty is fluid. See, many of these patients will be having newer comorbidities appearing every month or year. So you reassess the patient's comorbidities during every visit. Check the patient's renal function, that may be deteriorating. Check whether the patient is adhering. This is very important. When the patient is having warfarin, you may be checking PTINR, you know whether the patient is adherent. Here, we are not checking blood test. There is no blood test routinely done to assess the adherence. So, make sure the patient is adherent and look for other concurrent medications, bleeding risk, whether the patient is having anemia, there could be some octal bleeding. So, do this every visit. Reevaluate the stroke and bleeding risk at every contact, at least annually. And these are the do not do checklist. No antiplatelets. Do not use aspirin monotherapy. And even in post-PTCA patient, don't give triple therapy as far as possible. No patterns. Don't bother about whether it is a paroxysmal AF or permanent AF. Give anticoagulation. No bridging. Even if the patient is going for some procedure, minimize heparin bridging during interruptions. During interruptions, many people would be tempted to give heparin. That may cause more harm. No automatic switching in stable patients on warfarin. And whatever said and done, certain patients, their life expectancy would be less than 1 year, and with advanced dementia. Here, palliative care is more important. Deprescribing is valid and compassionate. So, to sum up, this is how the practical dilemma is solved systematically. Assess the patient, comprehensive geriatric assessment, use AF care loop, calculate CHAT score to assess the risk, calculate Hasblat score just to modify the risk factors, control the rate, often that is sufficient, rhythm control for symptoms, prescribe anticoagulants, preferably DOACs. Here I would prescribe apixaban 2.5 milligram BD because the patient has got very high age and a creatinine of eGFR is also low. Deprescribe aspirin, NSAIDs, reevaluate the patient for comorbidities and frailty at every visit. So, dear friends, confident care for the very elderly. You manage the risk, don't avoid treatment. Thank you.
Thank you, Dr. BINO. Excellent presentation. So, elderly patients are a high risk when we start anticoagulant, and it's a spontaneous bleeding or a minor bleeding with a minor trauma. So, we need to weigh the risk against benefit during anticoagulant. Thank you. The topic open for discussion.
You told about limit the drink for the 3 drinks per week. No, don't we have elements of?
Okay, this is a recommendation.
For the HA recommendation, you can have a 1.5 drink per day.
No, those patients who are taking more drinks per week, more than that, the chance of bleeding is more, the chance of fall is more. Maybe because of that. That's the recommendation.
Yeah, okay.
Recent times, very clear. I just want to ask one thing. Usually somebody is above 80 or 85 and we want to start NOAC. Our usual choice is apixaban, and 2 out of 3 criteria should be satisfied to reduce the dose to 2.5. Yeah. But practically, if the eGFR is normal and if the weight is also decent, for an 85-year-old man, in your routine clinical practice, do you start 5 BD or 2.5 BD?
That's a tough question. Most of the time, I may be starting with 2.5. There is one data with an edoxaban. Usual dose is 30 milligram, but here, even if you give 15, you will get an equal stroke prevention with less bleeding risk. So you can consider that, but we don't have data to support that. Many of the time, I would be tempted to give lower dose in elderly, very elderly.
Sajan, it's an excellent question, because there is a data which shows that underdosage is more problematic than normal dosage. So I prefer to give a normal dose, that is 5 milligram twice a day, unless there is a strict contraindication or a strict indication for a lower dosage. Strict indication for a lower dose is what you suggested. Creatinine more than 1.5, age more than 80, weight less than 60, 2 out of 3 criteria. Otherwise, it should be 2. And if we are using the rivaroxaban, most of the people, elderly, will have EGFR of less than 50, so it is 15 milligram. Fantastic, Bino. Thank you.
Thank you.